Welcome everybody to today's e-seminar, which is a case conference held by EUROD, an initiative by the CKD-MBD working group of the ERA. Today's topic will be a patient with CKD and an atypical bone fracture after long-term use of bisphosphonates. And the speaker today will be Ricardo Neto, from Portugal, and the panelists are Martine Cohen-Solal from France and Satu Keronen from Finland. Welcome to all of you. I will start very shortly with some words about the EUROD initiative, in case you have not heard about it. I hope you have. So the EUROD initiative was started for almost 10 years ago as a European initiative to revitalize the use of bone biopsy as a clinically useful tool in daily practice. Recognizing the difficulties we have in identifying renal osteodystrophy in our patients, with CKD, especially with advanced CKD. And we also acknowledge that bone biomarkers have not been established yet as equivalent clinical tool. But bone biopsies are becoming more and more rare due to the competence both in reading the biopsies, in performing the histomorphometry, but also the clinical tool to take bone biopsies in the nephrology clinics. And we do hope that we can stimulate its use by building up a European registry of bone biopsy results, useful for clinical interpretation, useful for research, and also by a close collaboration with bone biopsy registries in other parts of the world. North America, South America are two regions with strong bone biopsy registries, so we are very happy to have a worldwide collaboration. And of course, what we are experiencing right now, education is a very important part of EUROD. You all have heard about the e-seminars that we have started, case discussions, which have been ongoing for several years now. And we also have consensus statements that the EUROD initiative organizes each year. We publish approximately one consensus statement. These are two that already are published and have been very widely cited. The European Consensus Statement on the Diagnosis and Management of Osteoporosis in Chronic Kidney Disease Stages G4 to 5D, an area where previously very little guidance existed. And also the recommendations for calcium intake in adults and children with chronic kidney disease. In addition, we organize the EUROD winter meeting, and next winter will be the 8th EUROD winter meeting, which will be held in Leuven. It's always in Leuven, so it's easy to remember. And it's always the third week of January. So next meeting will be January 15th to 17th, 2025. Everybody's welcome to these meetings. They are usually of very high quality. And now I would like to welcome our speaker. Ricardo, please go ahead.
So, good afternoon to you all. Let me start by thanking the EUROD for the invitation to be here today. I'll be sharing with you one of our clinical cases that I really hope you find interesting. I have no relevant interests to disclose. So, this is a case of a 65-year-old male with a history of osteoporosis, hypertension, stage 3A CKD, and dyslipidemia. He was on ibandronate, supplementation with calcium and vitamin D3, and enalapril, and ezetimibe plus simvastatin. In September 2018, this patient was taken to the emergency room of our hospital because of his severe left trochanteric pain following a low-impact fall. A pelvic X-ray was performed, and it revealed a fracture in the left femoral shaft distal to the small trochanter. This patient had no apparent risk factors for fracture, since he had no smoking nor drinking habits. He had never been on steroids. There was no previous personal nor parental history of bone fracture, and he denied prolonged immobilization. However, upon medication review with the patient, the medical team found out that the patient had been under bisphosphonates for many years, almost 20 years, in fact. First alendronate and later ibandronate. Somehow his prescription just kept being renewed over the years. And after successful osteosynthesis procedure, the patient was referred to the rheumatology outpatient clinic, and the bisphosphonate obviously being stopped. On the initial workup, the patient had a serum creatinine in 1.33, corresponding to an eGFR of 55, so stage 3A CKD. Serum calcium and phosphate were normal, as were other bone metabolism biomarkers such as 25-hydroxyvitamin D, alkaline phosphatase, IPTH, beta cross-lapse, and osteocalcin. There were no vertebral fractures on X-ray, but the DEXA scan revealed low bone mineral density, especially at the femoral neck, with a T-score of -1.9 at the lumbar spine and -2.9 at the femoral neck, which would be suggestive with the diagnosis with the osteoporosis. At this time, the room colleagues discussed the case with us. This was in fact, an atypical femoral fracture related to long-term use of bisphosphonates, but the reality is that CKD-MBD might also have contributed to this situation. There was no help, as we can see from the results, the biochemical results. There was no help from traditional bone metabolism biomarkers, which are not reliable predictors of bone histology. Let me just show you data from our bone lab supporting just that. So despite a trend for, this is data from our pre-dialysis patients cohort, and despite a trend for rising levels of IPTH as one moves from low to high bone turnover, from right to left, we see that there is considerable overlap. So you can get low bone turnover with IPTH levels as high as 150 or even above 200. And on the other hand, you can have high turnover bone disease with IPTH levels as low as 40, as you can see on the right. In our cohort, alkaline phosphatase performed in a similar way, just like IPTH. So at this time, it was felt that a bone biopsy could be helpful in the management of our patient, and a bone biopsy was performed in June 2019. Please don't mind the artifacts that have resulted from the biopsy procedure and also from the Goldner trichrome staining. But even at low magnification, you can see that trabecular bone volume is reduced, and that is also, there is also a loss of trabecular connectivity. Here at low magnification, we can see that cortical bone thickness is also reduced, and at higher magnification, we cannot detect much osteoid. There is very low osteoid, even though its thickness is normal, but there is very low osteoid. You can see, by the way, in green, we have mineralized bone, and in red, we have unmineralized bone. So osteoid that has just been produced and is in process of mineralization. So you can see low of it, even though its thickness is normal, but you can see no cellular activity. You see no osteoblasts, no osteoclasts, no eroded surface. Fluorescent microscopy revealed just some very, very weak tetracycline single labels. And even though dynamic parameters as a cause of that could not be calculated, static findings were compatible in terms of TMD classification with diagnosis of low turnover disease with normal mineralization. So what we would call a dynamic bone disease. And the question now is, what would you do next?
Thank you very much, Ricardo. I think this question will be posed firstly to the panel.
Yes, thank you, Ricardo. I would like to first ask that, do you know what kind of kidney disease this patient had? And had he received any kind of specific treatment for that?
So, CKD was attributed to high blood pressure. That was
Okay.
the etiology that was presumed.
Okay, so kind of like a nephrosclerosis or
Right.
something like that. Yes. And then I'm also very curious. You said that the patient had been on bisphosphonate for almost 20 years. That means that he had been like 45. And do you know that he has been studied, any further about this osteoporosis? I mean, he's a male and relatively young. What could be the reason for the osteoporosis?
Well, that's a very good question. We can't answer it. In fact, you're absolutely right. Why should a 45-year-old male with no apparent risk factors for osteoporosis have been prescribed a bisphosphonate so early in his life? We don't have an answer. We couldn't get his past records. We don't know if back then he had already been diagnosed through a DEXA scan. We don't have we didn't have access to those data, and
Okay.
so really we couldn't answer that question. That's a very good question. So
yeah, so you don't really know what was the reason for the bisphosphonates. Was it like a DEXA scan because there were no previous fractures?
yeah, we don't.
Okay, thanks.
Yeah, and I have an additional question. This because this is a feature of early onset osteoporosis, what we call in young people, and we can also have some information about the fracture rate in the family, because this patient has a low bone turnover, treated for a long time with bisphosphonates, so he has an atypical fracture. So this is absolutely classical, but sometimes this occurs when there is early onset osteoporosis with genetic mutations. That could be also thought when we ask about the fractures in the family. And assess genetic in fact, but at least the fracture in the family.
Yeah, right. That's a very good question. As far as we know, the patient had denied any parental history of fracture, but that's as far as we know. That's only data we have. Yeah.
Mm-hmm. Okay, so but it's an interesting information.
Yeah,
That's
definitely.
really, yeah.
Right.
Okay. So what did you do with this one?
So
May
back to the clinical case. So
Ricardo, may I
sorry?
just also have a very short question to you? So you showed us the bone markers, and it was very instructive how PTH can vary greatly within the same area of bone turnover. You also showed us alkaline phosphatase, and my question to you is, was this alkaline phosphatase taken before or after the fracture? Because alkaline phosphatase after a fracture is not a very useful marker because it will increase, but before a fracture, alkaline phosphatase may be a much more relevant marker and actually may outperform PTH in diagnosing turnover.
Right. It was taken after the fracture, on the initial workup, after the patient was being discharged from the hospital and being referred to the outpatient clinic. So after the fracture.
Thank you. So that's what I thought, because it was relatively high, and this could partly at least be due to the fracture.
Absolutely.
Okay. So back to our case, the room team decided to, in face of the histological results, together with the clinical, the lab, and the radiological data, to start analog treatment with teriparatide, which the patient did in October 2019. Supplementation with calcium and vitamin D3 were maintained, and non-pharmacological interventions were taken, such as adequate nutrition with enough calcium intake, and exercise was encouraged. Treatment was well tolerated, with no relevant side effects such as hypercalcemia or hypercalciuria, and there were no further fractures during follow-up. And then, 2 years after starting treatment, renal function was stable, despite 25-hydroxyvitamin D levels being on the low side. The remaining biomarkers did not change, and the DEXA scan was repeated, and it showed a gain of about 25% of bone mineral density at the femoral neck, with a T-score that coming from minus 2.9, as I've shown you, to minus 1.7. And in order to evaluate the histological effects of teriparatide, it was decided then to repeat the bone biopsy. Unfortunately, just like the first biopsy, there are also some artifacts in this biopsy. Sorry for that. This was related to both the procedure and the staining, but you can clearly see that in comparison with the first biopsy, total bone volume is increased, and trabeculae have regained some of its normal connectivity. Also in low magnification, we can see that cortical bone thickness has improved, and at higher magnification, it is visible that osteoid there is now much more osteoid in comparison with the first biopsy. Its thickness remaining normal, just like in the first one, and we can now identify cellular activity. You have an osteoclide in the upper part of the slide, in its lacuna, with some eroded surface, and just on the middle of the screen, you can see a small layer of osteoblasts producing osteoid. Fluorescence microscopy again showed only some single tetracycline labels, and this table depicts the change of histomorphometric parameters before and after teriparatide. You could say that bone became metabolically more active after treatment with teriparatide, which improved bone formation. And because formation prevailed over bone resorption, the result was increased bone volume. And although dynamic parameters could not be determined, the static results suggest that bone histology has become normal, or at least within the normal spectrum. In fact, for most patients, after a 2-year course of a PTH analog treatment, an anti-resorptive agent is typically started to preserve gains in BMD. This is a special case, however. It's an atypical femoral fracture in a CKD patient with severe dynamic bone disease after many years of bisphosphonates, who after a 2-year course of teriparatide have an improvement of bone formation and volume. So what would your next step be? Would you adopt an expectant approach? Would you just go for a second course of teriparatide? Would you now switch to an anti-resorptive treatment with denosumab to consolidate bone gain? Might there even be a place for romosozumab, an agent that has both anabolic and anti-resorptive effects?
So, should we answer or let the answer the, yeah? Mathias, you're muted.
Please, yes, we hand over to the panel. Very interesting questions and very interesting case.
Yeah, and also I have also other questions because I'm surprised about the markers that you're measuring. We don't do that here, for example, because, for example, osteocalcin is very difficult and not reliable. And we know that teriparatide is the specificity is to increase another marker, which is the P1NP. And this is what we use in CKD and non-CKD patients just to ensure a good response to treatment. So you don't do it because it's not available, it's not reimbursed, or because this is very interesting marker for teriparatide. This is the only one that increase after 1 month or 3 months of treatment.
Right. In fact, it isn't available in our hospital. And we don't usually check the beta cross labs and osteocalcin in our patients, at least we as nephrologists, but these were ordered by the room team, that's why I put them here. But otherwise, we don't usually check these parameters.
And how about the bone-specific alkaline phosphatase?
We don't do it either, unfortunately, in our hospital.
So this is a very interesting and relevant discussion, of course. And in this respect, we could say that there are, of course, proposals for reference markers. So for the non-CKD population, it's CTX, which was checked here, I think, at an earlier stage, and it's also P1NP, the total P1NP. For CKD, these two don't work, and hopefully we will soon see a new publication, a new recommendation recommending bone alkaline phosphatase and tetrate-resistant acid phosphatase 5B as the two reference markers in CKD. So this is something we can be looking forward to. But of course, experience is still very limited, at least with TRAP 5B. So may I ask at this point a question that comes up from the audience? At which PTH level would you use teriparatide? Does anybody want to respond?
Well, if I think you can treat osteoporosis in CKD3 just as you would normal population. I think it's reasonably safe. Usually you don't have any hyperparathyroidism at this stage.
I don't know if there is any kind of questions. There is animal questions, but not animals, but humans. It works. There is one publication, a recent one, in GBMR that showed that there is a response to teriparatide, and it was low on the turnover. But we all have this experience, as a matter of fact. Here, I'm a little bit surprised to Ricardo to see that the osteoclast surface does not change that much. The osteoid surface increased dramatically, but the osteoclast surface does not increase, which is quite surprising because teriparatide increased the remodeling. That means bone resorption and bone formation, and the balance is increased, not only the remodeling. So I'm very surprised not to see an increase in resorption parameters, while there is a huge increase in formation. So do we have an explanation about that?
Yeah, you're right. We were surprised by that as well. In true, bone formation improves it improved much, very much in comparison with the first biopsy, and in fact we would expect resorption to go up as well, but it didn't. Yeah, you're right, and that was perhaps the reason that bone volume increased so much from a value of 12% to 19%, which is it was a very big increase. But I agree with you. Yeah, there is really a mismatch between formation and resorption. Yeah, a very big mismatch. Yeah.
Because in your observation, everything is very consistent. You have an increased bone mineral density, an increased BVTV. So this is the only part which is a little bit surprising. So coming back to your questions, what should we do next? So as far as I'm concerned, for me, it's phase 3D. So we know that unless we have a transition to inhibition of resorption, we will lose the gain in BMD. So denosumab is one of the options, but can we use also bisphosphonates again in these patients?
I agree with Martine. Yes, that I would go for the denosumab not to lose the gain received.
Yeah. We have to do the transition for sure.
Yes, but I have no idea if you can ever again express bisphosphonates. I'm not sure about that. Which is of course a little bit problematic when the patient is 65 and put on denosumab. Yes.
Very good discussion, yes. And I could also add from the audience that partly one question, a very quick question, atypical femoral fractures are usually bilateral. Did you check the other hip?
Yeah, it was checked. Yeah, there was no, and there was no fracture. Yeah.
Yes, and also from the same from Jaja Salam, a short reminder that indeed in this patient both P1NP, total P1NP and CTX are reliable because the patient actually has a very early CKD, only CKD3A, so that is very true. An interesting question, would you have started the same treatment without a bone biopsy? This is very much touching the heart of Europe.
Anybody? So who should, Ricardo should answer, or what?
Oh,
Well, that's a very good question, and it was really one of the reasons that we decided to go for a bone biopsy, because traditional bone markers are not reliable. This was a very special case, a very serious case, and since we have this tool at our medical school, at our hospital. That's why we decided to perform the bone biopsy. So it's very hard to tell what to do without a bone biopsy, at least in 2024. But you're right, this is a very early stage CKD. This is a different scenario it's very different from a pre-dialysis or scenario, yeah.
yeah, if I have also a little bit biased view because I have access to bone biopsy, but maybe it could have been possible to start with do the same treatment without biopsy. I mean, his vitamin D and ALP levels were normal, which suggests against mineralization defect. And then there is a long history of bisphosphonates, which then raises the suspicion of low bone turnover. So maybe, but to be quite honest, I would have done the biopsy myself too.
Yeah, me too. Not only because the availability of the platform, but also because it's quite surprising to have even classical, being treated for 25 years with biphosphonate. And this happens when there is a low bone turnover at the beginning. So the turnover is already suppressed. If we suppress it for too long, this very classical cause of atypical fracture. But now we know that it is probably underlined by some kind of genetics. I'm coming back to genetics, but this does not occur in all the patients who has received for a long time biphosphonate. There's probably a combination of different kind of risk factors, low bone turnover, the biphosphonate, maybe the quality of the matrix. And in that case, since it's quite rare to have such a factor, it's worth to do a bone biopsy just to make sure how, if the cellular activity or the cell number is here, just to make sure also if there is no crack in the extracellular matrix, for example. And so mineralization defect, for sure, you can find it because alkaline phosphatase was normal. And it has to be increased. Otherwise, we will not understand anything. But at least to check what is this in the bone and also what it is in the bone marrow, because it's often neglected. How is the bone marrow? Does it have any atypical cells? How is the immune cells in the bone marrow? For such a young, for rheumatologist, 65 years old and atypical fracture, this is unusual. And to discard a secondary cause. So I think it was very well deserved.
I do agree with you, and I think this workup would probably have been most interesting at the early stage when the patient was identified having a very young age osteoporosis. So then a bone biopsy and more genetic evaluation would have been very interesting to perform. I turn back to some interesting questions from the audience. So some questions are around adynamic bone, the question whether a vitamin D, for instance, is useful in adynamic bone. There's also a question about romosozumab. And while it's still not very widely available, the question is if anybody has experience with it. We know that there are some publications, but is there experience specifically maybe in adynamic bone? And I think there's also a question which is touched by these two questions, and is whether the patient had any cardiovascular complications or any vascular or cardiac calcifications. Do we have information about that? And would that influence treatment?
Okay. So we don't have any information regarding vascular calcifications. No, there was no information about that. And what was the other question, Mathias? Sorry, before that one.
Whether it's safe, or what is your opinion on vitamin D treatment in adynamic bone?
Okay. Okay.
Active vitamin D. I'm sorry, active vitamin D in adynamic bone.
Okay. So I think that it would be safe to use, and perhaps we should do it, use native vitamin D in these patients, but not an active form of the vitamin. I wouldn't use active vitamin D in a patient with a dynamic bone disease. This would perhaps have potential to aggravate the disease. But I think that there would be room for the native vitamin D supplementation with the native form.
Sorry, because the patient, he just have CKD stage 3. There is no dialysis. So I don't see why active vitamin D could help.
Yeah, very good point. So the patient should be able to convert native vitamin D to the active form still in his kidneys. And there's also a question, it's not really stated here in the question from the audience, but it was used in this case as a supportive treatment for teriparatide treatment, but would you give it as a primary treatment? Any thoughts about that?
Any thought about how to use? I didn't get the point.
Vitamin D as a primary treatment.
No, probably that wouldn't be enough. Yes,
we cannot do that.
Wouldn't be enough. Yes.
Any comments about romosozumab in this case? It was one of the alternatives here.
So Ricardo, would you like me to answer?
Well, we have no experience with this agent in Porto. I feel that we have still very little data on romosozumab. There are still some concerns in terms of cardiovascular safety. So I think there is even much to be explored about romosozumab. But in a certain way, romosozumab would be an ideal treatment because it improves both formation and addresses at the same time resorption. So at least in theory, this seems to be an ideal solution. But from the time being, there is very little data about its use. I think we'll have to wait some more time.
Yeah, and especially for atypical fracture, I don't remember reading anything about the use, but maybe I'm wrong. So I'm coming back about the second course of teriparatide. Because in that case, the patient responds very well, in fact. There was a large increase in BMD, BVTV, because we have the biopsy. So why do you think we should plan another teriparatide course? Because the patient is almost at the target in terms of BMD. So what will be the target, in fact? My question is that, should we consider the target in CKD patients the same that in non-CKD patients? The target being the T-score at the hip -2. Yes. Yeah. Below -2. Is there anything that would think that we should consider a different target, or should we use the same one?
So the question is about the treatment target or treatment indication?
The treatment target, because in that case, teriparatide has been used. It is really a success. Then, so after 2 years, we need to stop and do something else. So should we transition because of the possible loss of bone gain that has been obtained? And for how long should we treat if we opt to treat with denosumab? For how long, and when should we stop?
Yes, so this is an interesting question, especially since teriparatide now can be given longer than 2 years. So when is it meaningful in a CKD patient to stop treatment? This is certainly something that the speaker or the panel can try to respond to. I think it's experience from CKD, at least, is still very limited regarding the treatment effect on fractures. So I think we would have to rely on the data that we have from non-CKD patients. And I think this is a very difficult question to answer.
Well, I have a question for Martine. Do you have experience of the prolonging the teriparatide treatment over 2 years?
I have no experience because in France, 2 years is the maximum of treatment.
Yes, it's the same in Finland because it's due to the reimbursement also that.
So what we do in patients without dialysis, of course, but in this case in particular, is that we check with P1NP because it's a good way to see the response to treatment. And then what we are doing now is we just treat 1 year.
Okay.
And then an inhibitor of bone resorption, denosumab or bisphosphonates. So in that case, it would be bisphosphonates because he had atypical fracture. And then back to teriparatide. So that means that we can gain, because we know that it's difficult to follow the response of teriparatide by BMD. The only way we have to follow the response is really the use of P1NP. And then the BMD does not increase that much. In that case, it was very good, but sometimes, half of the time, it doesn't increase that much because the osteoid, that the bone that is produced is undermineralized. So we don't have an increase in BMD after 1 year or 1 year and a half. And then when we treat, because it's osteoid mainly produced, or denosumab with an inhibitor of bone resorption, then we will see the mineralization of the osteoid that has been produced and an increase in BMD. So all that stuff, just to say that we are lacking also markers to know when we have to stop and when we have to start again. But I have no experience below above 2 years. And patients with CKD, they have also an alteration of the bone marrow. When we look at the bone biopsies, for example, there is a lot of different kind of cells that are not atypical, but there is most of the time a lot of cells in the bone marrow compared to the non-CKD patient, at least for the dialysis patients. So I'm quite reluctant to use teriparatide for a long time, at least.
Yeah.
So I think the few studies, often pilot studies that are published in mostly advanced CKD, show a very, very good response to anabolic treatment. But on the other hand, this was also done in patients with very low bone turnover, where we maybe can expect a better response. So the question here still open, how to go on. I think we have some suggestions to maybe just wait and see, and in this case follow bone turnover markers, see where they lead, and get an idea of what is happening in the bone by following the bone turnover markers. Ricardo, do you have a continuation of the case?
Yes, I do. Yes, I do. Thank you for your excellent comments. I think that, at least in theory, that any of these four approaches would be, at least in theory, reasonable. But I'll tell you what the room team did. So the rheumatology team chose to proceed with an expectant strategy, maintaining supplementation with oral calcium and vitamin D. And in fact, the patient remained clinically stable. No new fractures were diagnosed, and biochemistry parameters were also stable. But then, unfortunately, the patient died last year when repeat DEXA was just about to be repeated, and we don't know the circumstances of death. Actually, this became known to me upon reviewing the case for this presentation.
That was a tragic end, and it's also making a very big question mark behind the whole treatment. Was this due to CKD-MBD? Was it maybe still a late effect of long-term bone turnover suppression? Do we have any data on anabolic treatment and mortality? As far as I know, not in CKD patients specifically. So should we go back to the panel and see if you have any additional comments here?
No, I think it's good. I'm always surprised to add oral calcium. In that case, CKD stage 3, because I don't see what will be the contribution of the calcium supplementation. In most of the studies, and it has been a lot, the supplementation in calcium doesn't help in terms of PMD or in fracture. So here it's a stage 3, so I wouldn't have done that. We used to consider a good diet, ask them to have a good diet, but not calcium supplementation, because it has been shown that it doesn't do that much.
So you would, Martine, so you would just keep vitamin D supplementation?
Yeah.
And when you say good diet, you mean what amount of calcium in the diet, and how would you measure that?
We do 600 milligram per day.
Mm-hmm.
So 2 dairy product a day is enough. A glass of milk, two yogurt, 1 part of cheese, which like not in France, as you know, but in many other countries. And if they don't want to have that because of the cholesterol, they can drink also mineral water enriched in calcium, 0.5 liter a day. Much better.
I think that's quite in accordance with the 800 milligrams that are recommended by the consensus recently published by also for advanced CKD.
Exactly. And so in the normal diet, provide also 200 milligrams, so 600 more is enough. And there is one question about what are the dietary calcium requirements in patient and in patient with CKD. Do we have an idea if there is a difference between CKD and not CKD patients?
Not to my knowledge, no.
I don't think so either. I think what is important and what we have unfortunately been a little bit too reluctant to do is to guarantee that our patients receive enough calcium. And this is probably a combination of both phosphate restriction, which often reduces calcium content in the diet, and also a fear of oversuppression of PTH, a fear of adding calcium because of the risk of vascular calcification. And I do think that if we do not over-treat with calcium, then calcium is really a very, very valuable treatment for our patients with advanced CKD, with dialysis patients, with dialysis CKD, so CKD-5D. So we have another interesting question. If this patient had not died, so how would long-term follow-up have been regarding bone markers, regarding DEXA? How often should we do a DEXA scan in this kind of patient?
Very good question. So, Ricardo, what would you say?
I don't think we have enough data to answer that question. I think it was reasonable what the rheumatologist was thinking about, of repeating the scan 2 years of stopping teriparatide. I think that was a reasonable plan, but I don't believe we have a final answer to that question. But it really is a very good question.
So we do not have scientific answers, but we can have also experience. In that case, I think that 2 years after is too long, because if we do not have any transition treatment from teriparatide to something else, at this stage, if we don't block the bone resorption, we will see a decrease in BMD after even 1 year. So in that case, because it's absolutely special with atypical fracture, I would have done after 1 year and not wait 2 years, because that means that what has been gained in 2 years would have been lost in 2 years. It's not easy to follow this kind of treatment because it's a daily injection. So it's a little bit, it's not like having a treatment like every 6 months or 1 year. So it's a lot of constraint for the patients doing that. And since they accept the treatment, they also accept the follow-up because it's not easy to do. So this is my experience, at least.
Yes, very true, very true. So in the short term, make a DEXA after maybe 1 year, but for the long-term follow-up, I think it depends, of course, very much on the bone markers. I think bone markers would be very, very valuable here to guide us in the long-term follow-up. They're easy to take. And we do have a good dynamic, and if we use the right bone markers already in early CKD, we know that if the patient has progressive CKD, we can follow them throughout the CKD. So if we use the bone alkaline phosphatase, if we use TRAP5B, we can follow the patient through the development of different CKD stages. And then, depending on what happens with turnover, it can be expected that maybe a DEXA can be timed a bit earlier, a bit later, but we do not have very good long-term data on how frequently we should check a DEXA. There is some more questions. Let me just scan through here. So I think an interesting question that was posed before the seminar is let me see. How if the proportion of patients with adynamic, with atypical fractures is the same in CKD as in non-CKD, are CKD patients especially prone to adynamic fractures or not? Any comments by the panel or by the speaker?
I think it has to be registered because it's absolutely very, very rare to have a typical fracture. It's 0.001% of the fractures. So, for example, in our hospital, which is a big one, we have one atypical fracture every year, which is nothing because we receive 500 femur fracture every year. So we have been analyzing that for over 5-6 years. So among those ones, none of them had CKD. So that means that unless the records are very well done and written the CKD and the atypical fracture, we will not have the answer. But it's absolutely rare. So that's why this observation is absolutely unique.
Yes.
Yeah, I agree.
Thank you very much. And I do think that we need to round up now because we are closing in on the end of the session. So maybe, Ricardo, do you still have additional slides?
Yeah, thank you for your valuable comments. Yeah, I'd like to finish with just some short conclusions. So CKD patients, as we know, are at increased risk of fractures, which lead to disability and increased mortality. Unfortunately, CKD patients are often excluded from clinical trials and recommendations for fracture risk reduction. And moreover, the presence of mineral metabolism disorder in CKD patients turns harder the identification of patients at higher risk and that would benefit from treatment. And despite new serum biomarkers and imaging modalities that are emerging, bone biopsy is still the gold standard for the classification of renal osteodystrophy, but in fact, this should not prevent treatment of patients with high fracture risk, especially in earlier CKD stages. Established diagnostic and therapeutic strategies, just as teriparatide, seem safe and effective in fracture risk reduction in earlier CKD stages, but clinical trials are badly needed, especially in pre-dialysis patients. And last but not least, the clinician should never forget to regularly review medication with patients in order to avoid iatrogenesis. That's a very important lesson.
Thank you very much, Ricardo. And I think with this, we can conclude. Let me just, can you stop sharing your slides then?
Of course.
Thank you. And let me once again remind you of the EUROT case conferences that are in the future, in the near future. The next case conference will already be in November 12th. Then we have 2 more booked for spring 2025 in March and in May. And please do not forget the winter meeting, which will be held in January in Leuven, Belgium, both online and in place. So you're very welcome to join us. With this, I think I want to conclude today's session. Thank you very much, everyone who participated. The very, very lively discussion was excellent. And also thanks to the speaker and the panelists for excellent contributions. Thank you and bye-bye.